Retropharyngeal abscess. Retropharyngeal abscess is a collection of pus between the posterior pharyngeal wall and the fascia and muscles covering the cervical vertebrae. That's a retropharyngeal abscess, which is a collection of pus between the posterior pharyngeal wall and the fascia and muscles covering the cervical vertebrae. The retropharyngeal space is a space bounded by the buccopharyngeal fascia anteriorly and the alar fascia posteriorly. It includes the retropharyngeal lymph nodes, and because serious infections of teeth can spread down this space into the posterior mediastinum, it is often confused with the danger space. The danger space is actually between the alar fascia and the prevertebral fascia and extends from the cranial base above to the level of the diaphragm below. The retropharyngeal space is bounded by the buccopharyngeal fascia in front and the alar portion of the deep layer of the deep cervical fascia behind. That is the retropharyngeal space sandwiched in between. The danger space, however, is between the alar portion of the deep layer of the deep cervical fascia and the prevertebral portion of the deep layer of the deep cervical fascia. That is the danger space. These two components, however, cannot be distinguished either on an MRI or a CT in a healthy patient. So the two spaces are the retropharyngeal space and the danger space. Because serious infections of teeth can spread down the retropharyngeal space into the posterior mediastinum, it is often confused with the danger space. The danger space is actually between the alar fascia and the prevertebral fascia, and it extends from the cranial base above to the level of the diaphragm below. The retropharyngeal space is limited above by the skull base, below where the alar fascia fuses with the buccopharyngeal fascia at about the level of T4 and carina. Relations of the retropharyngeal space: superiorly skull base, inferiorly superior mediastinum, laterally the carotid sheath, anteriorly the buccopharyngeal fascia, and posteriorly the alar fascia. Retropharyngeal abscess is a pathology seen in two forms: the acute and the chronic. The acute form is commonly seen in children below 4 to 5 years of age. We do know that in the spaces of Gillette are tiny lymph nodes that disappear by about 5 years of age, and it is the involvement of these lymph nodes that cause the abscess to form in children below 4 to 5 years. It is as a result of suppuration of the retropharyngeal lymph nodes secondary to infection in adenoid, nasopharynx, posterior pharyngeal wall, sinuses, and tonsil. In adults, it may result as a direct infection due to some penetrating injury or foreign body. Chronic retropharyngeal abscess is usually seen in adults or slightly elder children. It is due to tuberculous infection of the cervical spine, as the pus directly spreads through the anterior longitudinal ligament. In children below 4 to 5 years, it occurs due to tuberculous infection of the retropharyngeal lymph nodes, secondary to tuberculosis of the deep cervical nodes. Retropharyngeal space lies behind the pharynx between the buccopharyngeal fascia covering the constrictor muscle and the prevertebral fascia. It extends from the skull base to the bifurcation of the trachea. This space, the retropharyngeal space, is divided into two by the midline fibrous raphe, and these spaces are called the spaces of Gillette. Each lateral space contains the retropharyngeal nodes, which usually disappear after 4 to 5 years of age. As the retropharyngeal space communicates with the parapharyngeal space and the posterior mediastinum, infection can spread to these areas. The prevertebral space lies between the vertebral bodies posteriorly and the prevertebral fascia anteriorly. The organism found in the pus in acute cases are Staphylococcus aureus, Streptococcus viridans, Klebsiella pneumoniae, Escherichia coli, and the Haemophilus species. The patient presents with a history of high fever, throat or nose infection, difficulty in swallowing, and in case of abscess extending up to the nasopharynx, there is nasal obstruction. In some advanced cases, there is restlessness, torticollis, and stridor or a croupy cough. On examination, there is neck stiffness, tenderness in the cervical nodes, and a unilateral swelling seen in the posterior pharyngeal wall with signs of acute inflammation. Complications like sudden rupture of abscess leading to tracheobronchial aspiration or laryngeal edema can take place. The diagnosis is confirmed as the WBC count shows leukocytosis with an increase in neutrophil count. X-ray lateral neck view shows an increase in the prevertebral soft tissue, and this usually is more than 2/3 the width of the body of the vertebrae. CT scan can confirm the diagnosis. Usually in an X-ray lateral view, there will be an air column with an air shadow above the level of the abscess. Treatment is incision and drainage of abscess, which is done transorally without anesthesia in a head-low position to avoid aspiration. Anesthesia is avoided as there is a risk of aspiration during intubation due to injury to the pharyngeal wall. In case of a child, it is done after mummifying the child by wrapping it in a towel and keeping the head low. It is important to have a good suction machine to aspirate the pus after incising it. To be very safe, pus can first be aspirated to decrease the pressure in the abscess cavity, and then the incision may be placed. Antibiotics are mandatory to take care of the infection, and steroids can be given in cases of stridor or croup. Tracheostomy is to be done as a life-saving procedure in case of severe laryngeal edema. Chronic retropharyngeal abscess is seen in two forms. 1. The lateral type, and this occurs due to Cox infection of the cervical lymph nodes spreading to the retropharyngeal nodes and forming what is called a cold abscess. It is only seen in children below the age of 5. The swelling seen intraorally is classically seen on the sides and not in the midline, as there is the central midline raphe. The swelling is fluctuant and with minimal signs of inflammation. The central type. It is due to Pott's tuberculosis of the cervical spine. The abscess is present between the body of the vertebrae and the prevertebral fascia. It begins in the midline and then spreads to both sides. It can be present at any age with restricted movements of neck and pain at the back of the neck. On oral examination, there is a swelling in the midline. In the pharyngeal wall, it is fluctuant and with less signs of inflammation. Hemogram in both chronic forms shows increased lymphocyte count, raised ESR, and a Mantoux test, which may be positive. The X-ray lateral view of cervical spine will show caries of spine with increase in retropharyngeal space and a Nash shadow in it. The CT scan can be done to confirm it. The treatment includes antitubercular therapy. Central retropharyngeal abscess is aspirated and drained in a head-low position without anesthesia to avoid aspiration of pus into the tracheobronchial tree. For lateral abscesses under antibiotic and antitubercular treatment cover, the incision and drainage is done, and this is done by an external incision in the neck at the anterior or posterior border of the sternocleidomastoid muscle. This X-ray demonstrates significant prevertebral soft tissue swelling, which is greater than 2/3 of the width of the body of the vertebrae, and this is a classic feature of a retropharyngeal abscess. However, this film is taken with the child relatively upright, and this can give a false feeling of prevertebral swelling. The child should be well retroflexed for the film to be appropriate.